I'd like to welcome you all to this session. My name is Fiona MacDonald. I'm a senior lecturer at Queensland University of Technology in Australia, and I am a very, very old alumni of the CAHR training program. I remember being here, at the first Health Law Conference held under the auspices of the training program many years ago, and as Lisa Foreman said this morning, it's curiously poignant to be at the to be here for the last year of the training program. It's been a wonderful experience for myself, and I know for many others. And I'd like to thank Lorian and the team at the University of Ottawa for organising this wonderful conference and this wonderful event. It's been a really stimulating couple of days, so we've got one more day to come. So I'm looking forward to it. So it's my great pleasure to introduce this afternoon's panel on safety and quality in healthcare. As we all know, safety and quality in healthcare has been a long-standing issue for the health system. If you think about the world's oldest surviving written legal code, the Code of Hammurabi, 1750 BCE, one of the things it dealt with was safety and quality in healthcare. So we've been dealing with this issue for thousands of years, but unfortunately it's particularly persistent. There are sort of two elements to the question around safety and quality in healthcare, one of which is prospective regulation. How can we regulate to make sure that patient safety-related adverse events don't happen? How can we regulate to make sure that healthcare is provided of the appropriate quality? And then secondly, there's retrospective regulation. How do we learn from adverse events? How do we learn from adverse events to ensure that adverse events don't reoccur? And additionally, how do we compensate persons who are harmed as the result of receiving healthcare treatment? And the three panellists today's presentations encompass all three elements, both those elements, prospective and retrospective regulation. So it gives me great pleasure to introduce the following speakers. And I'm going to do this very briefly because you all know them very well. So we have, firstly, Associate Professor Elaine Gibson from the Faculty of Law at Dalhousie University. Secondly, we have Assistant Professor Lorian Hardcastle, who is at the Faculty of Law, University of Ottawa, and is the Associate Director of the, and let me get this right, Centre for Health Policy and Ethics, Health Law Policy and Ethics at the University of Ottawa. And lastly, we have Tom Archibald, who is a PhD student also at the University of Ottawa. So thank you very much, and I look forward to your presentations.
Hi, everyone. I'm honored to be presenting in front of this august audience, and thank you for inviting me. Larry Gostin last evening invited folks to oversimplify, and I fear that this presentation has that's kind of where I'm headed in the time that's available, but we'll see how it goes. Uncharacteristically, though, I'm going to start with my conclusions, just so that you are clear on where I'm going in this presentation. The first conclusion is that the tort system fails injured patients. I don't have the slideshow going. That the tort system fails injured patients. And it fails, by the way, worse than other areas of tort, probably any other area of tort law. Second, there are a number of ways that we could go. I'm going to be speaking only about no-fault compensation, and my proposition is that it is superior to medical malpractice. I'm going to discuss the powerful forces that would resist implementation of a no-fault system, but I'm also going to identify recent developments that may weaken these opposing forces and that may make no fault feasible. And you're going to have to bear with me for a bit about what exactly I mean by no fault. I will get to that, believe me, but I'm going to set up the context as we go. My ultimate aim, by the way, is to establish that equality and equity would be enhanced if a no-fault system were brought in. Failures of the tort system in med-mal, or medical malpractice, The first two I'm going to mention but don't have time to discuss with you. Those are that substantive law doctrines favor healthcare providers in a way that is different than any other area of tort law, and that is rather surprising and, as I say, unique. There are structural disincentives to plaintiffs bringing an action in medical malpractice that also are big problems, but I'm going to focus on the Canadian Medical Protective Association and its role in causing the disequity that exists within medical malpractice. The Canadian Medical Protective Association, or I'll start referring to it as CMPA, represents 95% or more of Canadian physicians. It's a model that is unique in the world. In what way is it primarily unique? They describe themselves actually as not an insurer, but a mutual defense organization. What does this mean? They do not function like most insurance companies, which are driven, if, for instance, in an automobile insurance typical claim, the insurance company and the plaintiff are driven to settle at a certain point that makes the most sense in terms of setting a middle ground. This is not the aim of CMPA. It is to defend the reputations of physicians. So the whole model that usually functions in terms of reaching settlement does not happen in a similar fashion when it comes to a lawsuit against a physician. One Ontario judge referred to the CMPA's scorched earth policy in this regard. In other words, take no prisoners. They have massive resources to mount defense of physicians. Right now, as of this year, it's $3.2 billion in assets. This all results in a high degree of specialization among defense lawyers who work for the CMPA. We have far, far less of a specialization when it comes to plaintiff-oriented medical malpractice lawyers. In fact, usually they have to take on other work as well just to tide them over while they are dealing with the medical malpractice lawsuits. Adverse events in Canada. So Robert Pritchard in 1990 estimated that less than 10% of viable medical negligence claims are compensated for some of the reasons I mentioned and others. We had a major study by Baker and Norton about adverse events in the hospital setting, and they found that 70,000 approximately were potentially preventable. I want you to keep that figure in mind, that 70,000. Now, not all of these would necessarily be result in a judgment for the plaintiff, but keep in mind 70,000 potentially preventable events happening. Look at the CMPA figures in terms of civil actions resolved in 2014. The total is 1,092. That's how many civil actions were resolved. There are similar numbers that we could look at for claims commenced, but this is a useful tool. So we went from 70,000 to 1,092. Now look what happens to them. 587 of those 1,092 are dismissed, discontinued, or abandoned. This means plaintiff gets no compensation in more than half of all of the cases commenced. 394 settle, but then look at the court judgments. We have a total, 85 and 26, we have a total of 111 court judgments in total in all of Canada for 2014. And what happens in those? The physician is successful in 85 of them. The plaintiff gets compensated in 26 of them, and that is a percentage of 23%. The bottom line is that in 2014, 26 patients in all of Canada won a tort judgment in their favor in a case that went to court, and less than half of them who had commenced an action were successful in any way, even to get a settlement along the way. The stats, by the way, in terms of success rates are pretty consistent year to year if you track them over time. But surprisingly, the number of claims, well, maybe not surprisingly, given the lack of success, the number of claims is dropping. So look at the actions commenced against members. In 2000, 22.2 actions commenced per 1,000 members of CMPA. In 2014, 14 years later, 9.5 actions, so less than half. So more than half of a drop there. So there have been significant calls for reform, including by a few people in this room, certainly Joan Gilmore, Colleen Flood, and Brian Thomas. Not necessarily directly to go to no fault. That's the direction that I'm taking this discussion. But what are the forces in opposition? Well, one was certainly identified by Robert Pritchard, who had called for significant reforms following a review of medical malpractice in Canada. And 8 years later, he gave a talk about why not a single of his recommendations had been implemented, and he said that he thought inertia and complacency were really behind the lack of action, especially in comparison to a perceived malpractice crisis in the U.S. that Canada kind of thinks of itself as doing okay. The CMPA further is very strong and mounts a valiant defense of medical malpractice. And lawyers are very powerful in this, and lawyers stand to lose the most. And I'll talk more about that as we go along. So what has changed? Getting to the core of the talk, what do I think might be different now that might lead to things changing? One is the patient safety movement. So in the last 12 to 15 years, the topic of patient safety has become very high on the agenda in Canada. I just was in my local hospital in the last few days, and there were signs all over the place, and this is Patient Safety Week, and there were conferences going on. And so it's on the lips, I think, of every hospital in Canada, and the interest can be harnessed toward the concept of no fault. More on that to come. Second, the financing of physician defense. And third, the evidence of performance of no-fault systems internationally. And I'm going to spend some time taking you through these latter 2 points. The financing of physician defense. So taking Nova Scotia as our example, the CMPA fees in total for Nova Scotia physicians in 2014-15 were $7.5 million. In 2015-16, they are $15 million, and this is an increase of 98.1% year over year. So a shockingly high increase in the fees that physicians are to pay. And I don't have the actual statistics, but Nova Scotia is in a pool with all the other provinces outside of Ontario and Quebec, and so far as I know, they have this exact same fee increase. Ontario is very concerned as well. One estimate is a 200% increase over a 3-year period. So, is this a doctor problem? Is this a physician problem? By the way, the whole situation is under review right now, and CMPA is realizing that they may have a real problem on their hands because the provinces are very, very interested and concerned right now. Why are the provinces so interested and concerned? Well, one of the takeaways that I would like you to have from this talk is the role of provincial governments. For instance, back to Nova Scotia, until this year, the government has been contributing 90% of physicians' CMPA fees above $1,500. Some provinces pay 100% or 100% above $1,000. In Ontario, you can see the figures. The government is paying close to $200 million a year. And my takeaway is these tax dollars are being used to defeat the claims of injured patients. So it's a really kind of bizarre situation. There are reasons it's developed that way. It's problematic. I have had a 5-minute warning, so I have to pick this up a bit. The no-fault models then, getting to what we're talking about when I am urging no fault. So they can be limited to the type of injury. So 3 jurisdictions have a compensation program that is no fault, that is only to do with birth-related serious neurological injury. They can be limited by size of claim. Wales has gone for very small claims. France has gone to only the most catastrophic. It can be comprehensive accidental injury. New Zealand is unique in the world with that model. They can be specifically but comprehensively med-mal, or replacement of med-mal, and those are all the Scandinavian, all the Nordic countries. What are the ingredients? First, the creation of an administrative body. that will make the decision about whether a claimant fits within the concept. In the Nordic model, one of the following needs to be established: that the best practitioner would have acted differently, that the injury could have been avoided with another equally effective treatment, if the extent of injury that someone suffers exceeds what a reasonable patient should endure, if there's an equipment malfunction or a slip and fall. In New Zealand, it must be established that the treatment caused the injury. So with all of these, there is some test to be met, but what's really different about it, there's no mention of fault, there's no mention of blame. And so what happens instead is that the healthcare provider becomes an ally of the patient because there's no blame involved. They can support the patient in getting the assistance they need. It changes the dynamic between patient and healthcare provider significantly. There are some significant variations place to place. I described the Nordic and New Zealand tests. There are still in some jurisdictions an element of blame or fault that needs to be established. The access to the tort system can be blocked off depending on the program, or it can be the option of the person to go to no fault or to use the tort system. The awards may replicate the tort system, or there may be a reduced or capped award. The evidence of performance. So here's going on to one of the next catalyst for change that I'm talking about. Two recent studies that have been done. One was an actuarial study comparing fault and no fault accident compensation, and one was comparing the countries that have no fault to those who don't with the impact on total healthcare spending throughout the OECD. What did they find? Well, these are the factors that are superior to med-mal. There's a significantly higher proportion of patients who receive compensation, and it's received in timely fashion. Administrative costs are significantly lower. The healthcare provider becomes the ally of the patient, as I was saying. Transparency is enhanced because there can be more openness if you're not trying to hide whether there are grounds for a tort lawsuit. And the claimants are found to have better health outcomes as a result. So evidence of performance about cost, because I know that that's on a lot of your minds. So the actuarial tests found that the no-fault scheme's overall cost was similar, but there were more people compensated, so therefore the per-claimant cost is lower. The OECD study said that overall no-fault decreases the health expenditures per capita in a jurisdiction, and that's assuming an uncoupling of deterrence and compensation. In other words, those jurisdictions that still retain a fault element and need to establish fault do not realize the cost savings. There are some complexities or confounders, and one is the startup costs. One is the somewhat reduction in deterrence from a tort-based system. So one needs to have a rigorous system of error reporting and discipline that does not run with the no-fault but runs parallel. If the no-fault is optional, as I was saying, is a choice, then some of the benefits I've already mentioned are lost. Hospital liability, Lorian's going to be speaking to. It makes sense to have the hospital included in the no-fault system. A confounder is the perceived failures of Ontario Automobile no-fault, and so that needs to be dealt with. The government can control the compensation amounts, so there can be a loss of total amounts per claimant, like by individual claimant, I should say, and one can anticipate very strong resistance from the legal profession. So my conclusion is that you have reasons operating right now that blend principle and pragmatism. The principled directions are that patient safety will be enhanced and justice will be enhanced. The pragmatic matters are that no-fault systems are showing equal or superior performance on a range of perspective dimensions, and that the provinces have a strong incentive right now for financial reasons. Thank you.
Okay, so this is a really rickety platform. I feel sorry for all of you who have already presented. We apologize as the conference organizers for not springing on a nicer platform. So it is so great to be here with an audience filled with longtime CHR colleagues. I think Fiona actually goes back the longest. Fiona knew me when I was a 20-year-old 2L with no gray hair and no wrinkles. But also an audience filled with mentors and new U of O colleagues. So this is fantastic. So I'm going to be talking today about hospital governance and regulation of hospitals and how that impacts patient safety. So patient safety is a tremendous problem in our healthcare system, as our two previous, as Elaine and our chair alluded to. So these headlines are certainly not unfamiliar to you. These are actually all from the last 6 months. So doctors have cut off the wrong limbs, operated on the wrong organs, transplanted organs of the wrong blood type, left scalpels inside of patients, given lethal doses of medication, and many other sorts of horrifying stories. But are these just freak accidents? Are these just anecdotal examples? No. Elaine Gibson has already mentioned the 2004 Baker study, which found 70,000 potentially preventable adverse events every year. About 23,000 of those are actually fatalities, so about 23,000 potentially preventable deaths every year in Canada. And for a variety of reasons, those estimates are actually very conservative. It's likely that the real number is much higher. For example, around the same time that the Baker study came out in Canada, a similar study, just a few years before that, had come out in the U.S., which estimated about 100,000 deaths in the U.S. per year. And that was a study by the Institute of Medicine, a landmark patient safety study. That study has recently been revisited, and they've actually revised that 100,000 number to 200,000 to 400,000 fatalities per year in the U.S. So we can probably extrapolate that this study, the Baker study, which was based on a very similar methodology, that number is also probably quite low. So these two studies, though, they were important because they really catalyzed the patient safety movement. These studies led to studies into patient safety, extensive research into the causes of patient injuries, and really an exploration of this, what had been a somewhat unknown problem in the healthcare system. Unfortunately, though, the progress over the 10 years since, or I guess 11 years now, since the Baker study has been relatively limited. As Baker himself noted, 10 years after his study, he has said that Canadian healthcare is still not reliably safe, a prospect that few anticipated in 2004. So we have made progress, but it's been relatively limited. So some of you will know this, but a lot of my work has focused on tort law, so liability of physicians, of hospitals, of governments, and how tort law might make patients safer for a variety of reasons that Elaine has already alluded to. Tort law can only go so far. Tort law has its limits. We know from the Pritchard study that very few injured patients actually sue their doctors or hospitals. There are also a variety of limits on the ability of patients to hold hospitals or even governments liable. So because of these limits, and I'm happy, though, to talk about tort law in the question period. I love tort law. But for now, because of these limits of tort law, I want to talk more about other ways that we might get at this problem of patient injuries. So instead of looking at holding hospitals liable, I want to talk about how the way that we govern hospitals might actually impact patient safety. So more specifically, how do the existing laws that we have that regulate hospitals act as barriers to implementing the kinds of reforms that the patient safety literature says that we should be implementing? But also, how can the law be used more positively as a tool to catalyze the uptake of some of those reforms that, again, the patient safety literature says that we should be implementing? So why have I chosen to focus on hospitals as opposed to liability of physicians or ramping up the regulatory, self-regulatory, disciplinary efforts of physicians themselves? I think when we think about injuries, we do often think about physicians. And there's good reason for this. When we're injured, physicians were usually the last person to have their hands on the patient. Physicians are often the most spatially and temporally connected to an injury. And if you're scheduled for surgery, you're probably more concerned about how experienced is my doctor, what is my doctor's reputation, as opposed to the hospital. But evidence actually shows that that's misguided. Evidence shows that your outcome is actually more dependent on the hospital that you're going to and the volume of surgeries that hospital performs per year than whatever individual doctor you happen to get. Other studies have shown that under 30% of medical injuries are actually solely attributable to a health professional. So even though our instinct is to look to health professionals when something goes wrong, the evidence shows that's misguided. More broadly, during the years that have elapsed since the 1999 and 2004 Institute of Medicine and Baker studies, during that 15 years, a large body of literature has emerged saying that we should be focusing on the system's causes of injuries, not the individual providers. A lot of you will be familiar with this model. I talked right through a slide. A lot of you will be familiar with this model, James Reason's Swiss cheese model. What he's meaning to depict there is that we can have various kinds of problems within a healthcare system. You can have holes in the skills or knowledge or competence of individual health providers, of teams, but you can also have factors at the systems level. And so if you closed up any of those holes, then the injury wouldn't have happened. So the reason that I, and also the patient safety literature, chooses to focus on systems factors rather than individual or team factors is because if we don't fix the systems factors, providers can make the same mistake over and over again. If we focus on individual providers, but there's systems vulnerabilities, the same kinds of errors can happen over and over again. In addition, you can only do so much with humans, and you all know the expression, to err is human. We can tell providers to be more careful. We can explain to them how they should be more careful. They can intend to be more careful. But, when you get in a situation and you're making fast decisions, things are going downhill, there's distractions, you haven't slept enough, you're stressed, the mistake is going to happen. So we talked a little bit before about how when we think of an error, we think of the doctor who's most temporally and spatially connected to that error. We kind of think of the hospital as the opposite, right? These people sitting in a boardroom, nowhere near an operating room, weeks, months, even years before a patient is injured, they're setting some sort of policy. And the people on the board aren't generally doctors. Often hospital boards are comprised of lawyers, accountants, prominent local business people. And so we don't really think of these people as having any ability to affect quality of care. But the evidence doesn't show that. The evidence shows that when hospital boards are involved in quality of care, that does trickle down to patients. And so different studies look at different metrics, but by being involved in quality of care, I mean things like the board has specifically a specific committee devoted to quality of care. The board allocates specific time at each of their meetings to deal with quality issues. The board receives training in quality. Those kinds of things actually trickle down to patient outcomes. And so the early patient safety literature kind of speculated that hospital culture impacted safety, but wasn't really able to kind of empirically draw that connection. More recent literature does actually say that, when at the highest level of the hospital, efforts are made in terms of quality and safety, that actually does trickle down to patient outcomes. Okay, so then to recap, we know that there are significant concerns with patient safety. To that, we can add concerns with clinical practice variation, which is variation in the rates at which different hospitals or providers perform particular procedures with no demographic or other explanatory factors for that. So in other words, we have these serious concerns with both safety and quality. We also know that you guys all saw my eyes go wide when she flashed that sign. And I don't see any of my students, but you'll know what I'm about to do. I'm about to cram 10 minutes of material into 5 by talking really fast. So we also know that hospital boards have this ability to impact patient safety. So what's the problem? Why don't hospital boards just become involved as the evidence suggests that they do? Largely because, and many of you who do many areas of health law run up against the issue of physician autonomy. It's a tricky issue. It's politically contentious. And so the model closest to me is what in theory, on paper, a hospital looks like. You have the board who's overseeing both the administrative functions and the clinical functions. But the model furthest from me is actually, and this is of course a generalization, but this is how practically speaking things function in many hospitals, that the board is really overseeing the administrative kinds of tasks and then largely deferring to, sometimes the language rubber stamping is used, of decisions that come from the medical advisory committee. So any kind of changes that I'm about to propose will disrupt this kind of structure that we're used to and can be politically contentious. But what kinds of changes do I envision? Of course, I can't catalog, all of the tweaks we might make to governance or all of the more substantive changes we might make. But I just wanted to give you an example of what I envision. So, for example, Ontario has attempted to move some way towards doing this. They implemented the Excellent Care for All Act, which very optimistic title. But basically, it does some of what I'm talking about. It talks about boards having quality committees. It talks about boards making quality improvement plans. They also say now that if, say, a member of the medical staff is on the board, they can't be a voting member. So there's a concern that they would wield an undue amount of influence or that there'd be a conflict between doing what's best for the hospital and doing what's best for their fellow doctors. And so, I think other provinces in general haven't come this far. I don't actually think Ontario has gone far enough either. And the legislation, the Excellent Care for All Act, is quite vague. Not a lot of concrete sort of things that the board will do to impact patient safety. So, for example, hospitals have to do surveys of patients, and the annual quality improvement plan has to have regard for those survey results. Not really clear what that means. Should they be developing performance targets? If there are concerns that come up over and over again in patient reports, should they be developing plans or strategies to address those specific concerns? We don't really know. Some of the very limited literature on this, which is a whole other problem, has said that in general hospitals developed fairly weak performance measures for themselves that then, of course, they could congratulate themselves for meeting. So in addition to these kind of less overhauling of the physician-hospital relationship kind of changes, there are other kind of more fundamental changes that could be made. For example, many of you know Doctors are generally not employed by hospitals, but rather they have hospital privileges. And the concern with that, and various organizations have come out against this. The Ontario Hospital Association is one, have said that this privileging model can be antithetical to patient safety because it makes it very hard to get rid of a bad doctor. And indeed, that was my experience when I worked in a hospital legal department, was because the hospital's legislation to revoke privileges, it's a whole administrative process to do that. So the doctor's entitled to a hearing before the board, to written reasons. This can be appealed to the Health Professions Appeal and Review Board, and then all the way up through the courts, and it often is. And it's at great expense to the hospital, so it does make it, this privileging model as opposed to an employment model is one thing that makes it quite difficult to, where there's a safety concern attached to a particular doctor, to get at that. And then I am only going to say a few words on the next one because it could be a whole talk or two in and of itself. But I think another area that we need to look at that certainly does affect quality of care is how we pay both doctors and hospitals. And there are, Ontario is talking a lot right now about reforming hospital payment. Various other jurisdictions have talked about pay for performance and tying quality to payment. To give you a concrete example, in the U.S., the Centers for Medicare and Medicaid don't reimburse hospitals for the costs associated with treating a patient for what they deem a never event, so something that just shouldn't have happened. And so that's another way that we could possibly get at quality and safety. So again, some of the tweaks to the Excellent Care for All Act or the Hospitals Act to make some of the commitments of the hospital board to safety more concrete and less vague, those would be a first step. These, of course, are bigger changes that, as I said, would be more disruptive to hospital-physician relationship and could be very politically contentious for the government. I'm being told to wrap up, but anyway, there's this kind of wide array of changes. I've given you an idea of some of the kinds of changes that I would propose, but ultimately, I think that the government needs to, and hospitals need to be prepared to butt heads a little bit with doctors, because it is clear that reform to both hospital governance and the hospital-doctor relationship has to happen as one part of improving patient safety.
Hi. Just wanted to say thank you to Colleen and Lorian for organizing this great event. And I'm a little taller than. Thanks. Thank you for arranging this great event and giving me a chance to present some of my ideas and some of my work to date. As you can see, the title of the presentation is Patient Safety and the Future of Nurse Collective Bargaining. And as it says, I'm a PhD candidate at Ottawa U here. Essentially, the basic arguments I would like to make, there we are threefold. Essentially, they all share in common the idea that starting from the systems approach to patient safety that Lorian was talking about, I see labor law as a potential force for advancing patient safety. And the reason I say that is because of the increasing awareness of a connection between the systems that are at work in a particular hospital or other care facility, and the sort of the group dynamics, the workplace factors that can lead to an increased risk of adverse events. And so in that sense, I'm kind of seeing labor law as a potentially prospective form of regulation of patient safety, that is to say, trying to get at the root causes of how mistakes happen. Obviously, as has been demonstrated already, the amount of the amount of urgency to the patient safety issue is increasing over time and has since 2004. And as I think we were becoming more aware that patient safety is less about individual physicians or nurses and more about the environments in which care is delivered and the impact of efficiency-driven measures and flexibility-driven measures upon the working conditions of nurses. So essentially, my arguments are that while the labor law system has the potential to be a patient safety, a valuable tool of patient safety, presently, as it's designed, the systems that are in place in Canada give insufficient attention to patient safety issues, either explicitly or implicitly, and I will get to that in a minute. Essentially, because of the historical and other factors that that shaped the labor law model that nurses bargain in, it acts as a kind of constraint on their ability to advance important workplace issues related to hours of work, scheduling, staffing ratios, and workload, among other things that tie into that have been shown to have a demonstrable link to patient safety outcomes. And finally, I'm going to suggest that some of the reforms that I've been thinking of to the labor law system that governs nurses and other health professionals, for that matter, can be reformed to give greater representation to patient interests and particularly patient safety interests. So that's essentially the conclusions that I'm driving at. And before I get into some of the scientific literature that's come up, I should just talk a bit about the labor law field, and you might be wondering why a person whose background started out in labor law ended up in the health policy field. Labor law, of course, deals with a very specific and historically specific subject matter. It has its own distinct heritage arising out of dramatic economic and social events in the 1930s, and it has developed over the last half century or 60 years a certain core set of values. It has certain sacred texts. It has a variety of people who, the model of labor law that was established in the 1930s in the United States continues to dominate labor relations in the healthcare system today. And so it is the background kind of culture, legal culture, that I should say, that it has informed the structure of the systems that are in 2015 shaping and, as I argue, constraining some of the choices that representatives of nurses can make in their negotiations with governments. So now moving on to some of what I can call I guess the broad name for the category of work is nursing research. There's been a great deal of research in Canada, the United States, and worldwide, Australia, and in Europe, on studying the relationship between the conditions in which nurses provide care and the rate of adverse events, or the prevalence of adverse events and medical errors. And these are just two examples. There's literally thousands of pieces that have been done in the last 15 years. There are, of course, empirical studies that study patient charts and follow scheduling patterns and try to correlate those things. Of more value in this regard are meta-analyses or systematic reviews of these studies, and I'm just kind of learning a bit about that myself. And so some of the studies that aggregate and gather the literature to try and provide a real synthesis of the knowledge that's being developed out there on the link between nurse working conditions and patient safety. For example, back in 2007, the Kane piece here is a systematic review. It looked at 2,858 studies, selected 101, and out of those concluded that higher staffing levels, that is to say a higher proportion of registered nurses to other practitioners, was consistently associated with hospital mortality reduction, lower odds of certain adverse events such as pneumonia, respiratory failure, unplanned extubation, and cardiac arrest. And that's just one study of many, many that have correlated nurse staffing levels and nurse working conditions with patient outcomes. A more recent one, of course, is the Arkin study, and obviously by the title, the topic of nurse to patient ratios comes up, and it has been correlated with a preventable, that is to say, using the same kind of terminology as the Baker and Norton study, the concept of a preventable error in the hospital, and so this is the kind of study, the research that kind of excites me in terms of thinking about how labor relations mechanisms or labor relations representatives of nurses and other health professions deal with patient safety issues and the impact that some of these conditions can have. And so now I'm just going to sort of give you a brief overview of our country. And as you can see, of course, labor law is a provincial responsibility. And presently in Canada, the way that the nurse collective bargaining systems have evolved is that each province has a very centralized bargaining structure that covers all acute, at least, care hospitals and regional health authorities in a very centralized structure with one single registered nurses union that speaks for the majority of employed nurses in each province. Nova Scotia is slightly different than the rest in that it continues to have two nurses unions that represent different nurses in different parts of the province. So the NSGEU, Government and General Employees Union, represents Halifax area nurses, and the Nova Scotia Nurses Union represents nurses in every other health authority. Of course, there's been a lot of upheaval in the last 6 to 8 months in Nova Scotia in this very field. So so there may be, they moved to a single health region. There's a number of very contentious matters going on around that. But this gives the basic structure that we have 10 bargaining systems going on at the same time in Canada. And these are the established unions that, and in Ontario we have the Nurses Association, Manitoba Nurses Union, Saskatchewan Union of Nurses, United Nurses of Alberta, Nurse Bargaining Association in BC. It used to be the BC Nurses Union, and then they added in licensed practical nurses and so forth. So that's the basic legal structure. And as we know in labor relations, impasses, at least under the traditional model, are resolved, at least traditionally, by the threat of a work stoppage, or at least in the case of healthcare workers, a limited work stoppage where an attempt is made to preserve essential services. So the majority, you'll see 7 out of the 10 provinces continue to use some form of a limited strike model where if there is a bargaining impasse between the parties, the union has the right to, as with all trade unions in the normal private sector system, to take a strike vote and place pressure on the government as employer to advance their bargaining demands. So that's the basic labor law model. The only exceptions are actually fairly significant. In Ontario, we have the use of binding interest arbitration, and in Alberta, it also has that, at least on the books, and as well in Prince Edward Island, although you can't see it, it's up over the island there. But in Ontario, since 1965, strikes have been prohibited in Ontario since 1965, and there have been a number of very contentious rounds of bargaining since then. So essentially, my research, I looked at, I did a broad survey of all of the collective bargaining rounds between the nurses' unions in all the provinces between 1999 and 2014, so about 15 years of experience. And in that time, there were 55 rounds of bargaining in the 10 provinces, and in some years there were many rounds going on at the same time, and in others things were fairly quiet. And out of those 55, I wanted to identify those rounds in which what I call patient safety issues were negotiated or debated or discussed. And what I mean by patient safety issues are, as I've alluded to before, issues related to scheduling, hours of work, and the ratio of nurses to patients. Now, nurse-to-patient ratios, as I'll explain in a minute, were very prominent in the Nova Scotia dispute last year. But I considered as a patient safety related round of bargaining any round that had one of those particular issues in it, or in which one of the parties made reference to patient safety as a value or a norm, which is fairly frequent. So I'll just move more quickly through to sort of summarize my findings on this point. In the roughly 15 rounds across all the provinces that, and I can't give you any specific examples at this in the time frame we have here, almost all of them were in the strike-based provinces, and in many of them, the threat of a strike created a very high, actually a patient safety and a very immediate patient safety issue, and that led to frequent government interference with the freedom to exercise the strike mechanism, and in some cases the imposition of government terms. And of course, Nova Scotia's experience in 2014, there was a very protracted labor dispute on the very issue of patient safety and nurse-patient ratios. The Nova Scotia government employed NSGEU and the government of Nova Scotia engaged in a very high-pitched debate about the inclusion of a term in the collective agreement that would mandate a certain minimum number of nurses be staffed for every per number of patients, and ultimately that led to a very dramatic showdown and the threat of legislation, and ultimately it still hasn't been resolved, and so the idea, I guess, the recurring pattern that I see is that because nurses are placed in an ethically difficult position with respect to the withdrawal of services as the only means by which they can advance patient safety issues, my argument is that arbitration, as we see it in Ontario, or at least my research has found that nurses' unions are better able to advance patient safety issues through arbitration mechanisms where evidence can be presented. And that happens at the local hospital level, and it has occurred at the central hospital level. So, in my view, the way to better represent patients in the bargaining process, there's a number of possibilities, and all of them would be potentially controversial from a traditional labor law perspective, but one might be to have a mandatory patient representative involved at the bargaining table, at the central bargaining table. Another might be the formulation of more detailed criteria for arbitrators and adjudicators to follow to decide these very important issues about hours of work, the number of shifts that weekend shifts that can be ordered, and so forth, and so that the decisions can be made on these issues and disputes can be resolved on the basis of evidence and reason, and less on the basis of public emergency and the creation of a public health crisis, which I believe is the result of the use of the continued the traditional labor law model. And so that's my. That's the end of it. that cartoon arose out of the 2014 strike. So I'd like to thank the CIHR program and the University of Ottawa for helping me with this. Thank you.
Thank you, and I'd like to invite anyone with questions or comments to come up to the microphone, and as usual, if you could say your name and affiliation, that would be appreciated. Thank you.
Those were all great talks. Thanks. I wanted to ask Tom. I thought your presentation was very interesting. What would you say to someone who might suggest that settling this question of patient safety and nursing ratios within the labor negotiations process is just inappropriate, that this should just be thought of in a separate context and legislated separately? Is that something you're looking at in your research?
Yeah, definitely. And that has happened, I think, in California and some American states where there have been nurse-patient ratios legislated. And there are some studies already underway that have been, asked the effectiveness of these mandated minimum nurse staffing ratios, and I think California is the best example so far. And I think there was some discussion of that option after the Nova Scotia Donnybrook, I guess, in 2014. And the idea that, by regulation, the Minister of Health or whomever could make it a regulation under the Public Hospitals Act of the province for there to be a certain amount, on the grounds that, it's just the raw numbers of people that you have on staff are a systemic factor. And in many cases, in many American states, that's the great thing, I guess, about being transnational. But the studies that I've looked at in California show that those measures actually do make a big difference in Medicaid hospitals, mainly. I think the ones that the public depend upon, the low-income public. So, yeah.
My name is Joe Colangelo. I am a lawyer. For the first 25 years of my career, I represented doctors through the Canadian Medical Protective Association, and for the last 15 years I've been doing whatever I want in health law. The first thing I want to do is to congratulate everyone that I've heard today, and it has persuaded me that healthcare advocacy is not practiced in the courts alone, and that the health law groups of the various law schools, 3 of which I know quite well, including this one, are just outstanding places for public interest advocacy, and I want you to continue, because in the current discussion about access to justice, I believe that your groups are going to be a critical part of the solution, particularly for the middle class. Because the solution is not going to come from the courts alone, from the profession alone, and God knows it's not going to come from the deep pockets. And I can tell you that after 40 years of seeing health law from various aspects, I'm persuaded that some form of no-fault compensation is appropriate, and that's not new. Rob Pritchard said that many years ago, but the government thought that his report was too expensive and didn't listen to him. I want you folks to continue the discussion, and I want to give you some ideas that I think you ought to take up. If you have reactions now, I'd be pleased to hear them. Number one, I believe that the form of no-fault compensation has to be premised upon a discussion with a whole number of stakeholders, and I encourage you to engage in a discussion not just with the medical profession, but with the other 20-odd regulated healthcare professions. And insofar as the medical profession is concerned, I think you would be surprised about the discussion with them. That profession is far more legally attuned and socially attuned to the no-fault debate than I think you might imagine. That profession has typically been male-dominated. And now, given the diversity of that profession, I think you're going to find a much more receptive profession to the discussion about professional accountability and no-fault compensation. The other thing I'd ask you to consider is this, is that in the broad scope of professional responsibility, insurance is an essential part of professional conduct. And whether you're a lawyer, a doctor, or a nurse, there has to be some form of insurance that ensures the defense costs of a proceeding. And you got to factor that into the consideration. And lastly, think about the issue, and this comes out of a case called Ferguson, and this goes way back, and the gray hair will tell you this is a decision of Justice Ferguson. Some injuries arising out of healthcare are inevitable. It's that 1%, 2% of patients who are going to get that quirky reaction to the anesthetic, and in my view, that's just part of the enterprise. And society should pay for that, because if I'm the 98% that benefits from a general anesthetic, the guy who is the quirk, the 1%, he shouldn't have to pay the price for the fact that I'm the 98% that benefits. And lastly, think about access to justice in terms of health care. Health care is an icon in this country. It's an essential part of the justice that we live. The guy who saved my life in emergency room last night, he did far more for my right to life and liberty and security than I ever did for any of my patients. Thanks for your consideration, and congratulations to all of you.
Well, thanks so much for your comments, and we've been in some discussion already by email, and I'm really pleased that Joe was able to come today from Toronto to join us. In terms of the discussion, it's a situation where I started out with physicians, and that probably was obvious in the way that I was speaking about it today, and I absolutely agree that the layers get more complex the more the more I review the topic, and as so many subjects tend to go. And especially, I think, actually, I mentioned only once, but the linkage between Lorian's and my presentations. A great deal of resources are spent in fighting between hospitals and doctors in terms of each trying to pin liability on the other. And if those resources could be going to patients instead of to the energy being spent sorting that out, then we'd come a long way towards getting more equitable compensation. I agree that the other healthcare providers can and should be part of a more major discussion about this. The insurance is certainly necessary. If CMPA is not going to fold tomorrow based on what I've been arguing here. And in fact, what I didn't have up is statistics about just how much of their time now is spent on regulatory matters, actually. In a way, it's all the more egregious, frankly, that our tax dollars are spent defending physicians against their billing fraud, their fraudulent billings, and defending them for that purpose, and also the criminal charges that they can be faced with, the sexual assaults, etc. The dollars are being spent on defending them in that way as well. But I digress a bit to say that some forms of insurance would certainly continue to be necessary even if there was a no-fault system. Of course, I agree completely about the unavoidable accident or unavoidable injury type of mal-occurrences that happen, and certainly from, I know I went through them quickly, but on the descriptions of certainly the Scandinavian systems and the New Zealand one, those types of incidents would be and are compensated, actually. So I'm entirely in favor of that. Thanks.
No-fault accident compensation is an interesting proposal. And so just a point of clarification. In New Zealand, as far as I'm aware, unless it's changed recently, they didn't cover this issue spoken about here, where you're the unusual one, where you react to the anaesthetic in an unusual way. That's specifically excluded. And the thing about no-fault compensation, at least as it's played out in New Zealand, is that it is, from access to justice perspective, many things are solved, but the problem is that over time, what you actually get in form of compensation has gone down and down and down and down until it's not very much, really, particularly if you're talking about a major catastrophic issue where, you've been significantly harmed as a result of patient error. So that's the, I don't know whether or not that means that you don't go for no-fault compensation, but certainly when you're talking about an egregious example of medical error that has caused significant physical harm to a patient, the actual compensation that an individual gets in the New Zealand system is pretty light. And a lot of it, what it does actually pay for in New Zealand to some extent, is that you bypass the public system and you get more timely treatment in the private sphere, and relatively, little amounts in addition on top of that. So that's one thing about no-fault compensation, and perhaps that may be not enough for us to think that, well, we wouldn't go for it, but it is something to give me pause over it. And the other thing I think is that I've always found it puzzling how I think some people think, and it's often the discourse in the patient safety movement, that no-fault accident compensation is going to improve patient safety. And I think there's absolutely no evidence for that whatsoever. None. Because if you look at New Zealand again, do they have much higher rates of safety and reduced rates of iatrogenic injury? They don't. They have exactly the same. The same sort of data that you have from Baker and Norton plays out the same in the New Zealand context. So, and why is that? Well, I think because you're still subject to disciplinary procedures from the colleges if you do screw up. And so perhaps that's what keeps them worried, if you want. So this idea that if it wasn't for the fear of being sued, then they would suddenly get all wonderful in terms of delivering on quality and safety. I don't see it. I don't see it in the evidence. And again, that's not a reason not to do it. And certainly but it's for different reasons then. And I think it would be a mistake to think that if we did bring no-fault accident compensation to pass, that the things that Lorian's talking about and others are talking about in terms of actually really trying to galvanise improvements in patient safety don't need to be done. I think they really need to be done, and very quickly. Sorry.
Wow. So you can tell by Colleen's accent that she is highly influenced by the New Zealand compensation scheme, which, as I mentioned, covers all forms of accident. And what has happened in New Zealand over the years with medical malpractice in particular, compensation, it has shifted and gone through its wrinkles, and it has certainly been subject to budgetary constraints. One thing I'm going to say is I think that Colleen's comments were really built around what happens in New Zealand and not so much in the other no-fault compensation schemes in the rest of the world, which I'll give you a bit more detail about. But certainly it's true that in New Zealand, the rates are quite low, definitely very low compared to what you would get if you had a successful tort claim. You know what? It's the same for workers' compensation in Canada. And I actually don't hear many arguments that we should be, although it has been litigated at times over the years, you don't hear many arguments that we should get rid of workers' compensation in favor of being able to sue in tort for our workplace-related injuries. In fact, it's a system that I think has been proven to work very, very well on average, even though, again, your right for a good amount of recovery is greatly suppressed. Other systems of no-fault compensation for medical malpractice tend to set the amount, well, unless they have, unless it's one that is just based on, for the Welsh system, it has a maximum of $25,000 in claims, but that's deliberate, and otherwise you're into the tort system. The Nordic country systems are meant to replicate what you would get in the tort system in terms of dollars. So it's a very different approach in that way. And likewise, the birth-related neurological injury programs that I talked about, they are meant to replicate what you would get in tort. In the Scandinavian countries, they can tend to put a cap on, but the cap is placed at around $2 million. So there's some suppression of the very, very top claims that we can get in Canada, but it's not much. All of that, I have to say when you're looking at comparisons between jurisdictions, you have to be very careful because so much depends on the social security net that exists in that country. And so, for instance, the discussion in Canada is very, very different from the discussion in the U.S. because our basic hospital costs are paid, as you know very well. Whereas in the U.S., you may well have to sue for those hospital costs. So so that's just one example, but also if you think of the Scandinavian countries and the type of social security net that they have, you know that we're looking at different dollars. In terms of patient safety, so I don't think you have evidence against that either, Colleen. And the basic proposition that I make is that to the extent to which the healthcare system can be more open about the causes of injury, and to the extent to which you can create much better reporting systems and loops for feedback to learn from our mistakes, which we have just an appalling provincially based system in Canada so far on that, to the extent to which a no-fault system would open that up potentially, then there could be enhanced patient safety.
I wanted to chime in on the patient safety piece, the deterrence piece. So in your question, Colleen, you sort of suggested that maybe the New Zealand model is, so tort law acts as a deterrent, and then maybe there's something else in New Zealand that's acting as a deterrent, like professional discipline or whatever. I actually think that it might just be the case that both are just not deterring doctors at all. So the reason that we see the same rates of error in, say, Canada and, say, New Zealand is not because tort law deters and because professional responsibility deters. I actually think that there's both are kind of poor deterrents. I think that there's a variety of things that make deterrence against doctors fairly limited. I mean, we talked about the fact that they're insured, and they're not insured in a way like you are insured in your car. If you run somebody over on the street, you're paying more in premiums. Their premiums aren't adjusted for their bad decisions. And the other thing is I mean, the deterrent comes so far after whatever you did wrong that, it's years later, and so I think probably none of this is a good deterrent. And so if we're going to do it, it would have to be for, I think, reasons other than, like, I know that argument is made lots, that no fault improves patient safety because people are open and all of this, but I think you're right that you have to have better feedback mechanisms to make that happen, and I'm not sure that tort law or no fault would really do that better.
We actually got to find this out by looking at other jurisdictions with no fault and see if all of the good rainbows and ponies things have come to pass. I mean, it's not, it can't, it must be able to be answered.
Well, certainly it's a claim of the Scandinavian countries that they have improved patient safety. I don't know that they have the statistics on it.
Yes, thanks very much for those presentations. I wanted to ask a question related to another area of the healthcare system, so I don't know if this is fair. Baker and Norton looked, as you said, at the hospital sector. That actually led a number of us, and I was involved in some of this early work, to look at patient safety in home care. Mm-hmm. So if you think we have variation in systems between hospitals, you ain't seen anything yet until you walk into somebody's home, where everybody has a system. We actually have photographed it. We have the descriptions of those systems through some qualitative studies, but everybody has a different system. So my question for you is, where is the field in terms of looking at patient safety in home care? And this is hugely challenging, I realize, because then you have the informal provider alongside the formal provider who's often in the home for a very short period of time. None of them have the protection that you have of the systems within a hospital. Obviously, there's interventions that don't apply, such as surgical interventions, but there's many interventions, and we have an increasing number of people in home care. That's going to just continue to increase. Extremely complex cases in home care, getting many forms of medical intervention, as you know. So I'd just love to hear where the field's at on that, because I haven't, you were focused more in the hospital sector. Thanks.
So the field is not as advanced as it should be with regard to not just safety in home care, but safety in nursing homes, safety in long-term care homes, safety in people who probably shouldn't be in retirement homes but are still in retirement homes. So it's the field is much less advanced, both in terms of kind of people arguing for ramped up governance, kind of ramped up regulation of safety, but also governments themselves seem to do less in that realm. Ontario did kind of review their nursing homes legislation a few years ago and whatnot, but the field isn't nearly as advanced as it should be there. And I think, as you suggest, we're going to have more and more patients in those settings, and also in a kind of continuous push to decrease cost. Home care providers, nursing homes, long-term care homes could be doing more, invasive, more advanced, more complex patients, and so that might just be sort of the next kind of frontier. And unfortunately, not only is there not a lot of literature on what we can do about the problem, there's not a lot of literature trying to measure it. I mean, it was easier for Baker and Norton to measure adverse events in hospitals than it is to measure adverse events among, as you say, you have these kind of conflating problems of the home care provider plus the patient themselves taking care of themselves plus family members. It's hard to tease out what the cause of an adverse event was and how that really happened. Whereas in the hospital, you have not always great, but better records. Who did what, and so it's easier to measure. And so I think one of the things that will get us to more people caring about lack of safety in nursing homes, home care, long-term care is better data to say, look, this is the magnitude of the problem. And so I think, for sort of the lawyers to get on board to say, oh, this is something we need to be regulating more. We almost need better data on the kind of health sciences side to show, X number of patients die a year in nursing homes. Well, I mean, a lot of people die in nursing homes, but that shouldn't die in a nursing home. So,
we've got time for one more question.
If I could just do one follow-up question based on the discussion that Professor Flood has raised. The issue of patient safety, in my view, probably isn't harmed by some form of no fault and may be improved. But in your further deliberations and your further considerations of this, you might want to think of it in this way. Compensating an injured patient is also part of his health care or her health care. Mm-hmm. The obligation to account for error and to fix it is a fiduciary obligation of almost every profession I know. And it, in the odd event when I represented physicians and an error occurred, and when I wasn't acting like a junkyard dog, I would, we would approach the plaintiff's counsel on a much more collegial basis and say, look, he's made the error, we're prepared to make amends for it. And 9 times out of 10, the case was resolved quickly, resolved for a lot less than what you got in court. Mm-hmm. And the patient didn't end up hating the physician. As a matter of fact, continued to have a certain amount of respect for him. It's a far healthier approach.
Unless anyone's got a response on the panel, I think this is it for this session, and you can all shoot off for a bit of quiet relaxation. But first, we've got our CIHR training program room.
This is actually one of my, not the 6th National Congress, my 6th year in the CIHR program, and I just want to say it wouldn't be, it's a great way to end the day, and I'm glad we got in our traditional Colleen Rainbows and Ponies comment before the day ended. Anyway, my name is Blake Chapman. I'm a seemingly perpetual doctoral student at the University of Toronto, and my interminable thesis is winding down, and it's on the ethics of nudging consumer behavior, individual behavior. And I would just hazard a statement regarding this panel, and the content of what we've talked about is that maybe nudging and those kind of small little subtle changes to choice context might have more promise than law reform for improving patient safety. Just maybe some topics down the road. But anyway, please join me in thanking our panelists and moderator today, Fiona, Elaine, Tom, and Lorian.